Good evening, everybody. Thank you for joining us tonight. I'm Dr. Jordaan of the Surgical Weight Loss Center, and I've got Deb here with me, who is one of our allied health professionals. We normally have patient information evenings in person, but we decided to have this webinar due to the current circumstances we all find ourselves in. We would like to give you a brief overview tonight as to what we can offer in terms of weight loss surgery, and then how we approach it in our unit. And Deb will also tell you a little bit more about the non-surgical side. We would like, could I have the first slide, please? Mm-hmm. So we would like it to be an interactive session. We've got Erin available, who is going to be available for live chat, so that you can pitch your questions as we go through the evening. And we would like to answer all of your questions.
So we've got Wayne here this evening. Wayne's one of our...
This is one of our patients, Wayne, who's going to give a short presentation.
Good evening, ladies and gentlemen. So where are we? About 2 years ago, I big eater, everything, go to Bali 3 times a year, got on a plane, and the air hostess hands me a seatbelt extension. With that, I'm like, no, not using that. So I forced myself into the seatbelt. Next morning, I had a medical condition where I just bled, and I thought, oh, okay, something's going on here. So with that, I contacted my GP, who I have had for 30 years, spoke to him about issues, had blood tests done, and my cholesterol and my sugar was through the roof. So with that, I suggested to him, do I go on and have a sleeve? And he suggested yes. With that, 4 years of doing light and easy, have no regrets doing that, but you lose 40, you put 70 back on the minute you stop. Food was fantastic, was great, but within the first week I'd eat, and then the second week I'd be like, no, I need to eat again. So spending all that money in the first 2 weeks, and then another week I'd be spending $300-400 on takeaway food, anything from 18 pieces of KFC in one sit to 9 to 10 caramel lattes a day, 6 cans of Red Bull. Each night was 3 packets of chips and a 2 litre of Coke, and then a 4 litre ice cream straight after that, and then back onto my light and easy. So it was something that I needed to do urgently, and so then my GP suggested, yep, a sleeve, so he recommended me to Dr Jordaan. So I made the consultation. The first minute I get to the door, I was sick everywhere because I was so nervous, because I was doing this journey on my own. I didn't want to put it on Facebook because a friend of mine had it done publicly and put it on Facebook and was just attacked by very close friends of ours saying it's all cosmetic, but really at the end of the day, it's my health. So I backed away from Facebook, didn't put it on Facebook, and so got upstairs, and the minute I walked into the door, I had the receptionist girls go, oh my God, you must be Wayne. And I'm like, you know, how's this? So from the minute I walked in that door, I felt home. I felt welcomed, and I thought, this is where I'm meant to be. So in that time, I was then taken into the consultation room and spoke to one of Jordaan's team there. She explained everything, the procedures and what was going on. Dr. Jordaan came in and went from, I thought there was only 1 step, but I didn't realise there's actually 4 steps. There's your balloon, there's your band, your sleeve, and your bypass. So he went through all 4 steps, and then he suggested to me that I have the bypass. So within that time, I waited for my insurance. Please, you must have insurance. It's highly recommended to do that sort of thing. I waited 12 months. That 12 months went fast. Day of the operation came. Again, Pindara was just, they were fantastic. They were so good. 7 hours later, I woke up into my room and I had no pain at all. I was there for 5 days. Everybody was coming in, checking on me and saying, any pain? I'm like, no. And so from then on, I took the journey and followed the amazing team, the dietitians, physio, the nursing staff, everyone sort of thing. Come to after the procedure was like, okay, what do I do now? The dietitians told me, well, this is what you need to do. And I'm like, living at home, working in medical myself, I don't have time to be cooking. So then they suggested tiny tummies, which to me were a godsend. They were just the best thing that these guys came on earth. Your whole 6 weeks of your food preparation is done for you. Rachel, who is from that company, got on and she said, right, delivered everything, and truly highly recommend her company. They are just fantastic. So with that, the 12 months going on the journey with the team, telling me, you know, yes, lay off this, no, have more of this. Medication time, your tablets. Yeah. I will be honest, I went to a stage where I haven't got time to be taking these tablets because you can't guzzle your water, you have to sip. So everything is just small sips, and to take these tablets sip, I just didn't have time. So my last appointment, yeah, they knew straight away because my levels were extremely low. So now I have to up on my medication and that sort of thing. So that's one thing I do suggest, is that you highly recommend you do take that medication, your vitamins and all that sort of thing that they say. But truly, I have no regret at all whatsoever. I had no pain, I had nothing. So yeah, a lot of it now is I'm having friends that I haven't seen 2-3 years. A lady this evening that I also works in health, I haven't seen her in 8 years, and bang, she's here tonight. So I truly recommend that you talk to these amazing teams and to Jordaan, because there's no looking back. Honest to God, there's no looking back. And yeah, you know, so, you know, that was January, and then that was then, I think 2 nights before the procedure, and we went out and I had my last meal, and that was one of everything just about. And then, because I thought, oh well, there's no stopping. So then, and then to now, 12 months later down the track, yeah. So sometimes I don't get cravings, so I've got to remember to eat and that sort of thing. Everything's all portion size, and now you can eat basically whatever you want to eat, but in that small portion. But the girls will tell you, no, you can't have this, you can't have that. But truly, highly recommend. The best decision in my life. And if it wasn't for these kids, I doubt whether I'd be here today. So, but yeah, truly, I thank you all for what you have done. You've given me a new life, and to Jordaan, and amazing.
I have to say, for us in the industry, it is so rewarding to see people like Wayne coming along and how they reinvent themselves and their lives. And it is definitely a very high energy discipline to be in. Let's get back to tonight's presentation. We would like to answer all your questions. Just brief introduction. I am from South Africa, qualified there as a general surgeon, came to Australia in 2001 and started this practice in 2007. Obesity is a disease, and we approach it like we would approach any other disease. And I think that's important because patients often feel judged by others and they judge themselves. But once you see it as a disease like any other, it changed the paradigm to that of, say, treating diabetes, which is a disease with very similar causes, but would be viewed in a completely different light if you make that shift. We don't understand the causes of obesity well, but what we do know is that surgery in this day and age, it offers the best treatment. The benefits of surgery, it speaks for itself in terms of incredible weight loss, and that enables people to reinvent their lives and all of those psychosocial benefits. To us, it's very important to also look at the improvement in life expectancy and the quality of life. And there are quite a few medical conditions which improve considerably with weight loss surgery. This is a diagram to try and explain this, which is a fairly complex topic, but One of the conditions that we would typically target is type 2 diabetes, and we would, with treatments, find that 80 to 90% of people experience a remission of their diabetes, which means that they can stop taking medication. Another condition that responds very well is sleep apnea, and our goal is to get patients to come off their CPAP masks. And there are quite a few others, like high blood pressure, which normally responds well, so the patients can usually stop taking medication. And I want you to look at the bottom where it shows that there is an 89% reduction in the 5-year mortality. Not all patients who have obesity would be considered as meeting the criteria for surgery, and we follow the criteria of the National Health and Medical Research Council. For all patients, they would be assessed individually to see where they sit on the spectrum. This is an interesting slide just to show what happens with lifestyle modification in a large study in the United Kingdom. And it shows the low probability of an individual being able to bring their weight down and keep it down. And I'll just point out to you the group where there's an initial BMI of 40 to 44.9, where 1 in 1,290 men would be successful, and in the case of women, it would be 1 in 677. So if you have tried this before and it didn't work, you're in good company. The operations work by portion control, hunger control. There's a change in food choices, which is quite striking. Absorption of fewer calories does occur, but it doesn't play a large role in the bypass procedures. And then there is the improvement in blood sugar control, which is quite striking, and it happens very soon after surgery. All of the operations are effective, and the choice of a particular operation is determined by the individual's circumstances. But it's very important to realize that all operations require long-term commitment to maintaining diet and lifestyle changes. In principle, we as surgeons can modify the anatomy and the physiology of the gastrointestinal tract. And the two main organs we target would be the stomach, which is a reservoir, which normally with a normal capacity of about 1.5 to 2 liters, and the small intestine, which is about 6 meters long on average, and where the digestion and absorption of nutrients takes place. An operation which I'm sure you've all heard of is the sleeve gastrectomy, which has a pretty straightforward design, and it offers the best chance of permanent weight loss with the lowest perioperative risk and risk of long-term complications and side effects. This is the most popular operation in Australia at the moment. And the benefits are that it's suitable for most people, good weight loss, good eating quality of life, minimal risk, and it's a good primary procedure. There are patients who would qualify for a gastric bypass. The Roux-en-Y gastric bypass is the one that has been used the longest, and it is mostly prescribed to patients who have severe reflux symptoms based on their individual assessment. There is another form of gastric bypass, which is known as the Amigo loop gastric bypass, or the mini gastric bypass, and this is an operation that is good for metabolic conditions such as diabetes, and it does have the benefit of reversibility. So gastric bypass surgery is good for type 2 diabetes, and it's reversible and can also be very good for reflux. And this is a newcomer. It has been performed since about 2007 in the world, and it stems from another operation which was designed in the 1980s, around 1986, 87. This is called a SADI, and it is an operation that is essentially based on a sleeve gastrectomy. And we recommend this to patients where a standalone sleeve gastrectomy is expected not to be strong enough as an operation, or where we would target specific conditions such as diabetes. So for those patients with a BMI above 50, it's a good option, and it is the strongest operation available in Australia today for type 2 diabetes. But I just want to bring you back to the point that surgery is safe, it's safe and it works, and compared to other operations, it actually compares quite favorably. A sleeve gastrectomy has approximately the same risk of as that of a gallbladder operation, which is a very commonly performed operation, and the risk of complications would be lower than that of a joint replacement. There are also endoscopic procedures which we offer in the unit, such as the endoscopically inserted intragastric balloon. And then medication. So we are talking about a medical weight loss program where medication is used as the therapeutic tool. So all of our interventions would need to be seen as providing patients with a tool to practice lifestyle modification, which ultimately leads to weight loss. And medications have really improved over the last period. The two that we use most commonly is Saxenda and Contrave. And in this current situation we have with the COVID-19 outbreak, this would allow us various options to help you with during this period of not being able to perform elective surgery. And I'll come back to this a little bit later. So it's important to realize that it's more than just the surgery. We have a very good allied health team who will help all of you to prepare for surgery and to follow you up long term to give you the best chance of long-term success. And Debbie, I think at this point you just want to tell them a little bit more about it.
Yeah, look, absolutely. Thanks for tuning in tonight, guys. Part of what we're really proud of with this program is, of course, as Dr. Jordaan has already mentioned, the surgery and the medical weight loss programs are a tool, and they will dramatically help you to get on the right path to reaching your goals. But one of the other things we work very hard at and closely with our patients is our multidisciplinary team. It's a team consisting of dietitians, nurses, a lifestyle and exercise therapist, and bariatric GPs that have a special interest in weight loss. And using this multidisciplinary team, we're able to put together personalised programs, and that offers patients long-term practical solutions to not only get them to their goals, but really importantly, keep them there and make it something that's easy for them to fit into their lifestyles. So how can we help you right now? At this point in time, we're in situations which can make things a little bit confusing or hard for people to understand with their head. And if this was something that was on your radar, something you were thinking about with regards to bariatric or medical weight loss, we can certainly still help you. We can help you with regards to a medical weight loss program. We also have personalised dietetic and lifestyle programs. And I guess what we really want to do is put you in a position where we're setting you up for success, so that once we can resume performing elective surgeries, you're ready for the next stage. And, you know, we want you to know that the support and the help is here for when you really need it.
I just want to, at this point, also just mention a little bit how we approach the situation with the COVID-19 outbreak. So the normal process would be to have an initial assessment, and prior to surgery, patients would then have a pre-operative low-calorie diet. At this stage, elective surgery has been ceased, and we don't know for exactly how long this period will last. I do appreciate that this is a period of uncertainty, and I do appreciate you joining us tonight. But I want to try and give some relevant answers to what you may have in terms of our current situation. First of all, it would still be a good opportunity to have an initial assessment and to know what would be the recommended procedure. It would be good to engage with our allied health team and to start making inroads with lifestyle modification, so that with practice and with time, it becomes second nature and it will provide a better post-operative result. In terms of the pre-operative diet, rather than doing 2 weeks of a low-calorie diet at the end of this period, patients can make use of our medical weight loss program and prepare them for surgery with the aid of this program. You can also start to experience the benefits of weight loss. You don't actually have to lose that much weight to start feeling the benefits. So if somebody would be losing 5% of their initial body weight, many of these medical conditions will respond quite dramatically. And especially if you are able to achieve 10% of initial body weight, which is quite achievable with the medications that are available and with applying the lifestyle modification program, then 10% of initial body weight loss is quite doable. And that, in many patients, can also achieve remission of diabetes. It's also shown that if you achieve better weight loss before surgery, you get better results with surgery as well. And that is why we think that in this period, you could start to enjoy the benefits of weight loss with a medical weight loss program and optimize your chances with surgery, and also position yourself so that you can have surgery soon after the restrictions on elective surgery have been lifted. And I think that we would be able also, with our way that we have structured our online program now and our online appointments, would be able to offer you all the services that we would normally be able to offer in person. And yes, we would like to thank you for your time this evening.
Yeah, absolutely. Thank you for joining us this evening. We hope that you have found the broadcast informative and helpful. But please don't forget to scroll down to the bottom, click on the link, and we will be able to email you your starter pack, which will include a recipe e-booklet. It will include our surgical booklet, and it will also offer you a free teleconsult. So thanks again, and we hope to speak to you again soon. Don't forget as well, people, that there is someone live right now able to answer any questions that you have also. So just head over and answer any questions that you may have. And Dr. Jordaan and myself are also here to answer any questions you have.
Yes, so we have a question here about gastric banding. Somebody wants to know more about gastric banding. In the world of bariatric surgery, there have been various procedures at various points in time that were quite popular. The gastric banding was very popular for about 15 years, up till probably about 10 years ago. It does provide restriction in that there is an adjustable ring with a bladder on the inside of that at the top end of the stomach. It provided good results in a large number of people, and in a country like Australia, it became quite popular. As with any implantable device, there at times can be complications that occur because of having a foreign body in the human body. And with time, we have seen problems like slippage and erosion, or the bands very often did not maintain the benefits, especially when patients got beyond about 10 years of having the band in position, where it was very hard to obtain optimal restriction. So in principle, it allowed us to understand a lot more about surgery and how it works for patients and the problems that can occur with putting foreign material in. At this stage, compared to the stapled, non-resectional and resectional procedures which are available, it is probably not as effective. It will probably not give you the same eating quality of life, and it will probably not have the durability, so that it has become less popular and would only be recommended to a very small subset of patients who meet very specific criteria. There's another question about if one's BMI is below 30 with type 2 diabetes. This is a bit controversial. We do in Australia have the criteria of the National Health and Medical Research Council, whereby if somebody has poorly controlled type 2 diabetes and ischemic heart disease, surgery would be recommended at a BMI between 30 and 35. Now, I do have to say that we are allowed to make an adjustment based on the generic heritage of a particular individual. So, for instance, those who are from the Indian subcontinent are more susceptible to the metabolic complications of obesity, and one would typically make a 2.5 point BMI adjustment. So if somebody would have a BMI between 27.5 and 30 and would be of the particular genetic background where it would be recognized as a specific risk for diabetes, one could make that exception, but it would need to be assessed on an individual basis.
So again, we'd just like to thank everybody for tuning in tonight and watching the broadcast. And don't forget to scroll down to the bottom, click on the link so that you can make sure you take advantage of your starter pack, and we will definitely be talking to you again all soon. Thank you very much.
Thank you, everybody.